So yeah, we're good to start.
All right. So we'll go through evaluation and treatment of concussions. We had originally set a chunk of time out to practice some lab stuff, more hands-on stuff. But since I think I'm the only person with someone else in the clinic with me, this is Rochelle. She's a student. I
From
don't
where?
know how. Alvernia.
Alvernia. That's a real place, huh? Seems like a make-believe land.
But
okay, same thing. Yep.
All right. So evaluation and treatment of concussions. So our objectives for today, so I won't read through them all, but these are all the things that everyone who's watching should be able to do by the time that we finish up going through everything. The main things being identifying like red flags and that differential diagnosis component of a concussion eval. So common causes, most people in the healthcare field know what the common causes of a concussion are, and we all probably could have don't always think about is people in different age groups and age ranges are at a risk of concussion for different reasons. So kids that are 4 years and younger are at an increased risk from falls and child abuse. Adolescents between 15 and 19 are at an increased risk from sports injuries and car accidents. And then people that are 75 and older are at an increased risk from falls. But in the United States, each year there's 2.8 million diagnosed TBIs, and concussions or a mild traumatic brain injury accounts for approximately 80% of all traumatic brain injuries. So if you do the math, that's 2.24 million concussions in the United States each year diagnosed. So a lot of times, again, sports injuries, you get injured, feel a little off a couple of days, then things kind of go back to normal. People don't always go to a doctor. So that number is likely a lot higher than because of non-reported diagnoses. Going into some of the physiology behind concussions, so there's two schools of thought. One that most people are taught and think of is the coup is when if you have an impact, the initial impact of the brain on the skull. The contra coup is that rebound, usually on the opposite side. And again, this is what most students are still taught in school, but there's also a neurochemical cascade component too, which is what a lot of the research is supporting more of right now. So with the neurochemical cascade, so a concussion itself is a metabolic injury, not a structural injury to the brain itself. So with the neurochemical cascade, it's thought that the sudden stretch of the neuronal and axonal membranes creates an influx of ions that were previously regulated. And then that stretch affects the ion channels and physical membranes, which disrupts the neuronal ionic homeostasis in the brain. So with that, you get an excessive release of neurotransmitters. So there's an increased activation of N-methyl D-aspartate receptors, which causes a depolarization in the neurons, which causes an influx of calcium ions into the cells and an efflux of potassium ions out of the cells. All of that leads to mitochondrial calcium overloading, which induces changes in the inner membrane permeability and malfunctioning, uncoupling of oxidative phosphorylation, and that leads to organelle swelling. And then all of that leads to an oxidative stress and an imbalance in ATP consumption and production. So that's really that main component. Is a lot of things happen and it throws off the balance of the ATP consumption and production. So it's really an energy crisis within the brain. So
for that part of it, can we just jump in and ask questions, Lauren? Is that okay? Is there anything we can do about that, or we just need to know about it?
Knowing about it is going to be the mainly that underlying factor. Nick may be able to jump in a little more with some more of like the neurochemical component of it, but that's mainly just what's leading up to causing that energy crisis in the brain. So something that does all typically heal on its own, and then we usually see those individuals who don't heal as well on their own.
And is there like testing that you can do to find out if that's the limiting factor, or we just kind of assume that, well, if the normal stuff that fixes the concussion isn't working, there's other complicating factors that...
So imaging for a concussion, so x-rays, MRIs, regular CTs aren't going to show you anything. In severe cases, sometimes a good idea to rule out like subdural hematomas, any bleeds, but regular imaging isn't going to show you anything. It should look all normal with a concussion. There is some, I'll have to double check what the imaging is called. It's not something that is typical, and I don't know if places around here do this kind of imaging. It's a proton MRS. I don't remember what the S stands for, but that can actually pick up the N-methyl deaspartate receptors. So in the one article that I had found, more severe concussions had less N-methyl deaspartate receptors, whereas less severe still had a higher amount of receptors. So that was one way that they were gauging the severity of concussions. I don't know if that answers your question or not.
Yeah, yep. I don't know if Nick wants to jump in. You asked him if there's anything. I don't know if Nick had to step away to get his chicken or not, but
That's right.
Oh, he's muted. He doesn't know he's muted. I muted everybody, by the way, so.
I'm now unmuted. All right, what was the question?
So Travis asked if there is anything that we can do to influence the neurochemical like cascade. I said you might be able to jump in with anything along that standpoint.
It'll be easier. I'll post it. I think there's a good article. I'll pull up one or two. Yeah, I have to find them. Hold on.
Okay. But
Dan, anything from your end on a nutrition, hydration perspective that you've read or seen about concussion recovery when it comes to this stuff?
Yeah, I mean, diet's definitely involved. The one concussion doc I follow definitely recommends like less of the processed flours, vegetable oils, that kind of stuff is gonna just exacerbate that inflammation.
Okay.
So moving on, this is just something that I found very interesting and kind of puts into perspective the amount of force that the brain takes on with a concussion. So G forces, just walking, we're under like 1G, like roller coasters around like that 5G, F-16 fighter jets around that 9. Average around that 100 Gs, but some of those harder like football impacts are nearing that 150 mark. So it's an incredible amount of force that the brain gets put under. So it just helps to put into perspective what's going on. General timeframes. So with most concussions, symptoms will typically resolve in a 7 to 10 day time frame, but approximately 10%, and I've seen some variation in that number, ranging anywhere from like 10 to 20 to 25% of individuals will continue to report symptoms beyond those 10 days. And there is some debate as to when the actual time frame for a like post-concussion symptoms truly is, but most will go off of that post 10 days to like a longer than 2 week time frame. You're starting to look at post-concussion syndrome. And again, those that their symptoms typically resolve in 7 to 10 days, those aren't that we're seeing. We're seeing those who continue to have those symptoms for multiple weeks. Signs and symptoms of a concussion. This list is not exhaustive. There's many signs and symptoms, but the most common ones that you'll see are the nausea, balance problems, dizziness, vision changes, sensitivity to light, sounds, fatigue, drowsiness, so that mental fog, and you can get some more of like the personality types of symptoms as well, with increased anxiety, depression, irritability, things like that. So red flags, and dipping into like that differential diagnosis. So this list is per the CDC for red flags following a concussion. Some of these are more specific to if you were treating on the sideline immediately after a concussion happened. So not all of them are directly applicable to an outpatient setting, but still things to keep in mind. So any abnormalities in cranial nerve testing would be a red flag. So that's where that one pupil larger than the other comes into play. So that would indicate an issue with the oculomotor nerve. Intractable headache can be usually is a common symptom of concussions. I would be more concerned with a worsening headache, especially right after the trauma. And that's where you would want to rule out any potential for like a subdermal hematoma, anything along those lines. But again, since we usually aren't seeing these patients so acutely, not something that would likely occur in our patient population, but still something to keep in mind. Slurred speech is another one. So there's two areas of the brain that are important when it comes to language. So one is Broca's area, which is in the frontal lobe, and that's responsible for the production of speech. The other area is Wernicke's area, and that's in the temporal lobe, and that's responsible for the comprehension of speech. So if someone's presenting with speech or cognitive deficits, in addition to any other deficits that we could address, they would likely greatly benefit from speech or even OT for more of that cognitive standpoint as well. Weakness, numbness, decreased coordination. With a concussion, you may see those symptoms immediately after the trauma, not something that we should really be seeing prolonged. So so obviously that would be more of a central nervous system issue. True muscle weakness, as opposed to their strength being limited by symptom provocation, isn't normal. Same thing with that sensation in the extremities. If that were the case, definitely ruling out any C-spine involvement, making sure there isn't any cord compression. That would be the biggest concern with global weakness, numbness. As far as the coordination goes, so the cerebellum is responsible for the coordination, and that's not something that you should be seeing after a concussion, you may, like I would do coordination testing to rule out, is it true discoordination, or do they appear uncoordinated because of visual deficits as far as like depth perception and that kind of thing goes. So ruling out true like cerebellar issues versus from a visual standpoint. I also included, for, again, not really our wheelhouse, but for toddlers and infants, any of the symptoms that are on the left side of the screen, but any crying, unconsolable, and not eating or nursing are also going to be red flags for the kiddos. This chart was from the guideline for concussion and MTBI for healthcare practitioners. And it's a 250-page document if anyone really wants to dive in and read it. But that link is in the references at the end too. But these are differential diagnoses related to concussion. And some of them, actually a lot of these, and we'll dive into it a little deeper, but many of these diagnoses can be exacerbated with a concussion. So just different things to keep in mind. If they have a history of it, chances are those symptoms will only be exacerbated with a concussion. So a lot of those mood disorders, any past cervical injuries or history, any vestibular problems, all of those things tend to just be amplified following a concussion. All right, different risk factors. So again, this chart was taken from the same document as the last one. The main thing that I really wanted to point out here, under the contextual factors at the bottom, they have female gender. So there is research out there that says males are more likely to get a concussion. However, females are more likely to report it and to report their symptoms. So if that makes sense to most people, men are going to be more likely to get a concussion, will likely be more likely to see females just because they will report their symptoms, whereas men are more likely to just brush it off. All right, so when Chris and I did our concussion class last year, we went through the different trajectories. I want to go through those again because this is a great way to really figure out the best strategy for treating patients who have those prolonged symptoms. So the different trajectories are that vestibular, ocular, cognitive fatigue, post-traumatic migraine, cervical, and the anxiety mood. As I said before, if someone has any of these issues prior to a concussion, that's likely just going to be amplified following a concussion. And especially early on, most people will fall into multiple of these categories. As things start to heal up, you'll start to see those underlying ones that are really giving them those prolonged issues. All right, so we're going to start off with the cognitive fatigue subtype, since that tends to be the most common early on following a concussion. So symptoms will likely fall into the lines of just that overall fatigue feeling better in the morning, but worse with increased cognitive or physical activity, may be described as like end of day symptoms, and they likely have more sleep deficits as well. During assessments, their VOMs would be normal since they don't really have those vestibular-based symptoms. Computerized neurocognitive tests would show global mild deficits across all of the composites, and deficits are more with the retrieval component of information as opposed to the encoding component of that information. And all the questions to ask during like the history subjective would revolve around increased symptoms with increased cognitive or physical demands. So treatment for these individuals, education is going to be key for them. So taking physical and cognitive breaks throughout the day is going to be the most important in managing those symptoms. But making sure that they take breaks and not naps. So napping is likely just going to further disrupt their sleep cycle and will lead to further fatigue by taking naps instead of just those mental or physical breaks throughout the day. Students may need accommodations throughout the school day when they do return to school. So that could be just rest periods throughout the day, extra time for assignments, minimizing like very stimulating environments like a cafeteria, things like that. Similar to return to work, might need some accommodations depending on what they do. If they have a very physically demanding job, may need to look at an option of light duty, things like that, and even accommodations for light and noise sensitivity. Same thing with students as well. For these individuals, a monitored exertion program, just appropriately challenging the patient but minimizing significant symptom exacerbation. So for any concussion rehab, you always want to get what their symptoms are at baseline when they come in. Any time that we're doing any type of activity, once we get to like a 2 to 3 level increase in any of those symptoms, that's when we need to stop, take a break, let those symptoms subside a bit. With persistent symptoms, sometimes they need pharmacological intervention, obviously something that we would refer out to a physician for, but something to keep in mind. Can be useful for neurostimulants if they're just that chronic fatigue doesn't ease up with those rest periods. May need some sleeping aids depending on how their sleep patterns are too. And then if those symptoms continue to linger without really any improvement, that's when referring out to cognitive therapy would be really beneficial for these individuals too. So, moving on to the ocular and visual subtype. So as I said before, if you have deficits in one area, likely just going to be amplified with a concussion. And this is one area where that really can become prominent. So any history of vision issues or vestibular issue, or we're going to get to vestibular. This is more so like those vision issues are likely going to be amplified. So risk factors would include like if someone has a lazy eye or strabismus, just being cross-eyed, if they've had to wear an eye patch in the past, any history of eye muscle surgeries, or even being prescribed reading glasses. Those are all things that can likely make someone fall into more of the ocular visual subtype. So for these individuals, symptoms were going to be like a frontal headache with any kind of visual work, difficulties with visual-based like classes and activities, feeling that pressure behind the eyes, having trouble like visually focus, and blurry vision and double vision. So during any assessments that you do, computerized neurocognitive testing, they may have visual memory deficits and delayed reaction times. And these would be because of its more of a problem processing the information, not with the issue of retrieving the information. On VOMS testing, likely have impaired pursuits and saccadic eye movements and impaired near-point convergence. We're going to go over the VOMS, which goes over those different components. There's a handful of different outcome measures and tests that we'll go through at the end too. When you look at convergence, you might notice like a convergent spasm, increased tone, accommodative insufficiency. So that's your ability to focus on near objects. So that's going to come into play with that convergence and the blurry double vision. You might even notice binocular vision deficits, so difficulty keeping the eyes moving together. When there's a lot of photosensitivity for an individual post-concussion, suspects more of the migraine subtype, which we'll get into next. But treatment for these individuals, so if the deficits are mild to moderate, they would likely benefit from vestibular-based therapy. So that's VORs, VOR 1 and 2, saccades, smooth pursuits, pencil push-ups, more of that normal vestibular balance-based type of therapy. With moderate to severe deficit.
What pencil push-ups again? I forget.
So that works on convergence. So just bringing an object like as close to the nose as you can. Once it gets to being blurry or you see two of them, have them focus on it until it becomes one. Early on, I'll have them focus until it's one and then restart. As they get a little better at it, they can focus and then try to bring it a little closer, try to focus again, and then restart. So there's a few ways that you can modify it as it becomes a little easier. But the convergence should be less than 5 centimeters from the nose. I've already worked with someone who was actually beyond 3 feet from the nose. Like we were just testing and I ended up putting a Post-it on the wall and to like back up on the stool until it's 1. And it was over 3 feet away. So sometimes you gotta, an arm length won't do sometimes.
Are they cross-eyed?
No, nope, just couldn't bring the eyes together. Yeah. So for individuals who have moderate to severe deficits or more complicated cases, they're just not responding to the vestibular therapy. That's when behavioral optometry and formal vision therapy may be necessary. And then physical exertion is typically well tolerated with these patients if they have more so that isolated like convergence deficit. But again, physical exertion shouldn't severely provoke those symptoms, and we should obviously still keep it that non-contact type of stuff. For the post-traumatic migraine subtype, since we mentioned that the ocular visual subtype is more suspected when there's a lot of light sensitivity as the driving symptom. So we'll go over this one next. Patients will usually complain of a variable headache that's intermittently severe. They'll often wake up with a headache, which could be cervical in nature, but if they don't have cervical complaints, then it's likely migraine related. Will likely have the nausea, light and sound sensitivity, stress, anxiety, also usually a lack of exercise, sleep dysregulation. Risk factors for these individuals, having a personal or family history of migraines, having a history of motion sensitivity. I found this one interesting, even a history of like a brain freeze when you're eating or drinking something really cold. History of like any vestibular disorders and anxiety. During assessments, the VOM should be normal unless they have a vestibular component in addition. And with computerized neurocognitive tests, you'll find verbal and visual memory deficits and speed deficits if there's a vestibular component too. As far as treatment for these individuals, very similar to if someone comes in with complaints of headaches. If their migraine based in nature, there's usually not a ton that we can do, being migraines are vascular in nature as opposed to more of a tension headache, things like that, where it's more muscular-based. But still important to rule out any other cervical or vestibular influence to help decrease their symptoms. Going into vestibular, for these individuals, symptoms are going to be that dizziness, nausea, symptom-induced with any like visually stimulating environments, feeling off balance. They might say they feel like one step behind. Risk factors would be if they had history of getting car sick or motion sensitivity, history of migraines, and anxiety as well. On assessments, the symptoms will likely be provoked with VOR and visual motion sensitivity when you test the BOMs. With computerized neurocognitive testing, would likely show deficits in visual motor speed and reaction times. For these individuals, it would be important to rule out for BPPV if the symptoms sound positional in nature. Anytime there's head trauma, that's a risk factor for BPPV. You can knock those crystals loose, they can get into the canals, and sometimes that can just compound the symptoms that they already have. The vestibular subtype is frequently seen with migraines and or anxiety because they share a lot of the same pathways. So when one is irritated, you're likely going to have a lot of irritation between all three of them. So you can also have migraine-related dizziness, or also known as vestibular migraines, and migraine anxiety-related dizziness. So if there's one, there's likely a component of all three as well. For treatment, vestibular rehab, something that I think we all have some background with. At the end stages, we can integrate like vestibular exercises into higher level sports specific activities, especially if their goal is to return to play, even for individuals that have a more active, physically demanding job. And sometimes pharmacological management is needed too for any mood disorders, anxiety management, sleep disorders, things like that. Going on to the anxiety mood subtype. So symptoms are going to likely include ruminative thoughts, so continuously focusing on how they feel, focusing on the concussion, being hypervigilant, being very fastidious, so very concerned with very specific details, feeling overwhelmed, difficulty sleeping. Risk factors are a personal or family history of anxiety or any other mood disorders. And again, migraines and vestibular orders are also a risk factor. With assessment, the VOM should be normal or only mildly provocative. So again, it'll be more provocative if there's a vestibular underlay to it. Computerized neurocognitive testing, it should be normal as long as there's, again, no vestibular component. If there is a vestibular component, treat that first, and that'll likely start to ease up on the anxiety as well as they start to feel better. Treatment, so addressing any vestibular or migraine components first. So once the vestibular component is resolved, then you can really focus on exertion-based activities and educating the patients on regulating sleep schedules, exercise, diet, hydration, stress management. That's going to be the most beneficial for these individuals, because the more that they feel they're in control, the less the anxiety is going to come into play, the better that they'll feel. And referring out as needed for any psychotherapy or pharmacological interventions as needed. All right. And lastly, cervical subtype. This is our bread and butter for ortho PTs. So any risk factors would be prior cervical spine injury, car accidents, any high velocity injuries, being unprepared for a hit, any strong rotational component to the injury. On assessment, the VOMs and computerized neurocognitive testing should be normal. Likely have like impaired cervical range of motion, upper extremity strength, the normal cervical deficits that you would find for any cervical eval. Treatment, do what we normally do. Typical cervical-based PT, making sure we rule out any upper cervical fractures, upper cervical instability, especially if they didn't have imaging done after. Whiplash, very common just due to the nature of most concussion impacts. But is that normal? Do what we know how to do best. Other medical management may need medications, injections, nerve blocks, massage, acupuncture, surgery, but a lot of that medical management, that's what we're trying to avoid with therapy. So going into more of like the outcome measures, different testing, things like that. Are there any questions before we jump into more outcome based? I see Nick shaking his head no. I'm just gonna go with Nick and Katie's head shakes. All right, post-concussion symptom scale. So I know this is one that I haven't used, but is a good one to, can I zoom in? I cannot zoom in. Something that the patient would fill out themselves, just rating, going off of how far out they are from their concussion, and then rating all of those symptoms on the scale. It's a good option. Again, it's not one that I've used in the past. I don't have a good reason for not using it. Just hasn't been one that's been in my toolbox, but a really good one to take a look at all of like those most common symptoms. And that can even help you start to determine like which of those subtypes they fall into if you're feel like you're kind of getting stuck, not sure the best way to help them.
Are you going to go into diagnosis? So is this a tool to diagnose somebody? And really my question is, you're walking down the street and your friend sees you and says, oh, wow, Lauren is a physical therapist. This kid just hit his head. Lauren, come over here. Does this kid have a concussion or what? Like, what would you do?
I wouldn't use this one, but I would use this one. So this is the SCAT-5, which has the first part of it, gives you the whole kind of rundown. First part of it is an immediate or on-field assessment. So this would be one that we typically wouldn't use in the office, but the rest of, other than the rest of it is assessment for like in-office or off-field assessment. So this is a good tool to use if you're not sure if they have a concussion or not. I'm going to go back to here. So the SCAT-5 symptom scale is intended for evaluating athletes that are 13 or older. There's a child SCAT-5 for kids that are 12 and younger, if that would be the population that you're with. Like I said, the first page of it is for an immediate or on-field assessment. And then the second portion is that office or off-field assessment. It goes through, part one is like the athlete backgrounds. Part two is symptom evaluation, which is actually completed by the patient. The third part is a neurocognitive screen that includes orientation and immediate memory and concentration. And those parts include reciting digits backwards and saying the months in reverse order. Part 4 is a neurological screen that includes a balance exam. And then part 5 is the delayed recall. So those words that you said in part 3 for that immediate recall, 5 minutes later, you need to ask them list as many of those words that you can remember. So this would be a good tool to use if you are trying to determine if they have a concussion or not. When I was looking through it, it looked very similar to some of the components of like the mini mental or more the memory-based outcome measures for older adults had some of those same components. But, does that answer your question, Travis? Okay. So the VOMs, this is one that I do use for everyone who has a concussion. I'll make sure I do the VOMs, if not on eval, one of the very first sessions, and reassess as we go throughout. So this is super handy because it not only tells you exactly how to do each of the components of the testing, but it even gives you the pictures. So as it goes through the VOR testing, first off, we want to get those baseline symptoms, record baseline for headache, dizziness, nausea, and that mental fogginess. And then each testing, so smooth pursuits, just the ability to, if you have like your fingers on either side, have them just bring their eyes back and forth. And I want to say that time frame is, there's a time frame in there for how long to test, but you're looking for 10 repetitions side to side. After the smooth pursuits, that was the saccades, some 10 side to side. Sorry, that smooth pursuit is following the finger as you trace. Easy to trace an H pattern. You're doing a lot of the cranial nerve assessment, which we'll get into in a little bit. But go on diagnose, try to keep it non-predictable. So they really have to make sure that they're following with their eyes and not just trying to predict where you're going to move next. After each one that you go through, we will want to get those symptom ratings again. If, same thing, once those symptoms go like 2 to 3 above where they were at baseline, I try to wait a little bit to let those numbers come back closer to baseline so you can get a true idea of which of these are truly provoking versus having those symptoms just build onto one another. The saccade.
Would you have to do the whole thing, or could it be like first time you do it, you might only go through the first 3?
Yeah, you could break it up.
You have to do them in order. Is that the point?
No, so you could do them in whatever order you want. That would be the important part of letting those symptoms come down to baseline so you're not getting that just building effect. But yeah, you could do them in any order.
Well, like if all of a sudden it's like they start off maybe at a 3, but after like the second or third one, like they're up to an 8 and it's just not really changing, like you're just going to stop, right?
Yeah.
Okay.
And if there's a space where they can hang out in the office where it is dark, a little quieter, help let those symptoms subside a bit. There's been times that we just can't keep going without those symptoms being super high. And then we just have to end the session a bit early. The saccades, that's going to be bringing those eyes side to side, keeping the head still for vertical and horizontal. The near point convergence, bringing a point as close to the nose as you can get it before you start to, before it goes blurry or you start to see double. Have a measuring tape handy so they don't have to do it again before So you can actually measure from the tip of the nose to the tip of the object that they're looking at. And again, that should be less than 5 centimeters. Anything more than 5 centimeters is going to be an abnormal convergence. VOR for horizontal and vertical. So we want to be looking at a fixed point and then turn the head side to side, keeping the eyes fixed on that point.
What's VOR stand for?
Vestibular ocular reflex. So that's your ability for your eyes to go in the opposite direction that your head moves to keep your gaze stable. So however fast your head moves, your eyes should move equal and opposite, well, equal in the opposite direction, but at the same velocity. So when you have trouble with your VOR, you may have some oscillopsia where your whole vision just bounces. That's very unsettling feeling for a lot of people. So, because even if you think when you're in the car, how many little bumps do you hit, but your vision just corrects for it? Imagine not being able to have your vision correct and everything is just like bouncing the entire time. Not fun. So VOR for horizontal and vertical. And the last one is the visual motion sensitivity. So that's where we're going to, we'll come all the way down there. So visual motion sensitivity. We're gonna come at it's like a 45-degree angle, sorry, an 80-degree angle from left to right. And then you're gonna rotate the whole body width. So those eyes stay focused on the thumb. And the reason that's, you do need a metronome, so you should maintain a speed of 50 beats per minute. And then you're looking for 5 repetitions back and forth. The reason that can be very provoking for even not someone who has a concussion, but for someone who has an impaired vestibular system, you are keeping the eyes focused on the thumb, but you see everything moving in the background, which is very tough for the brain to process that information. Any questions on the bombs?
Where in your eval
Yeah.
do you do this?
So if after subjective, I would rule out, like I would take a look at cervical range, upper extremity strength. From there, if I am thinking it's more, whether I think it is more vestibular based or I'm just looking to see which of those components are provocative, I would probably do this next. Since a lot of patients that come to us tend to be in more of that vestibular subtype or have some component of it. But there was one concussion course that I had looked, and their eval is essentially their first 3 visits of just doing a bunch of different tests to really hone in on which like subtype they truly fall into. A lot of times we don't necessarily have that much one-on-one time to essentially do 3 evals, their first 3 visits. But this would be something that I would try to do on the first visit, because a lot of the vestibular based stuff are things that exercises we can give them for at home too. So we don't always have to work on like the VOR, pencil push-ups, that kind of thing in the office if they have a good handle on it and can work on that at home too. So that frees us up to do more advanced stuff, more time to rule things in, rule things out. But I think someone else had a question other than Emily too.
Yeah, so what does positive look like? They just can't do it, or they get nauseous, or they have any kind of weird symptoms?
Yep. So for the smooth pursuits, just not, their eyes can't follow where your finger is moving. And that's going to be, could be an issue with either the trochlear nerve, abducens, or ocular motor nerve, depending on which eye and which like area of the visual field that the eyes can't follow into. We'll get into, like I said, cranial nerve testing to go through which cranial nerves control which eye movements. But for smooth pursuits, they just can't follow the track. For saccades, eyes just can't, you might see an eye slip or they just can't go side to side. And just the symptom provocation for saccades. Convergence, we went through anything further than 5 centimeters would be abnormal. For the VOR, as this is probably, you need to pay attention to the smaller details, but probably one of the easier ones to find more commonly that's abnormal. So if they move their head, if their eyes slip off of their finger and then come back as they go. So if, say, I turn my head to the right and my eyes went to the right, that would be an impairment in my left VOR. So it would be a right eye slipped with a left corrective saccade. Does that make sense? Okay. So they just can't keep their eyes focused because, again, that VOR is keeping the gaze stable. So as you turn your head, your eyes need to go the opposite direction. If that VOR is impaired, your eyes are going to follow your head. And then the brain says, hey, they need to be back this way. And that's where you get that corrective saccade.
So how do you separate that, like a concussion versus a vestibular problem? Like all of these tests appropriate for someone who has a vestibular problem and someone who might have a concussion?
Mm-hmm. Yeah, I've done the bombs with, if someone is presenting with what seems to be vestibular but isn't BPPV, this is something that I will do with them and really focusing on, because even with any kind of vestibular hypofunction, if one side's not functioning the same, these are all the things that we're going to do to work on the accommodation of the vestibular system to retrain the brain.
So you would do this. So if you did a Dix-Hallpike and like you couldn't provoke their symptoms, then you would move on to this test?
So I would rule out Dix-Hallpike and the roll test, make sure it's not posterior or horizontal canal. If I did the test, we always want to look for the nystagmus, but sometimes the nystagmus is so minor that we miss it, or something that would, that's where having like the Frenzel lenses can be super helpful, because if it's something that they've had an issue with for a long time, you can override the nystagmus. So you can be dizzy as all heck, but your eyes aren't moving if it's something that your brain has already gotten used to. So with the Frenzel lenses, when you take the vision out of it, you obviously don't have a point that you can fixate on to keep that vision stable, in which case then you'll see the nystagmus start to beat. But if, when I do any BPPV testing, the nystagmus is the hallmark that we're looking for. If they don't have a nystagmus, but they report that they are getting dizzy with a certain position, I'll still test the other side and do horizontal testing as well. If none of the other positions really cause any of that dizziness, there's no nystagmus, I'll still do an epi and then retest and see if that dizziness has changed at all. So in a perfect world, we would see the nystagmus, but sometimes with longer standing issues, people have just already learned to kind of control it. All All right. Any other questions on the bombs? No? Okay. I'm going to take that as a no. All right. Cranial nerve testing. If we did all of these in the office, they don't take long to do, but the ones that will be most likely affected with any kind of concussion or vestibular based type of influence is going to be cranial nerves 3, 4, 6, and 8. So to go in an easier order, the trochlear nerve innervates the superior rectus, not rectus, I am blanking. Cranial nerve 6 innervates lateral rectus, which abducts the eye. Oh man, I'm blanking. Trochlear nerve, superior oblique, that's the word, innervates superior oblique, so that depresses and abducts the eye when it's acting by itself. All of the other eye muscles are innervated by the ocular motor. So tracing the H pattern is a good way that you can get not just the ocular motor, but also the trochlear and abducens, just making sure you're going into all quadrants of their vision. For the other one that's also very easy to test and can be more affected with concussions is the vestibular cochlear. And an easy way to do that is if you're standing behind the patient, if you just rub your fingers like right behind their ear, if they can hear it, it's intact. If they don't hear it, then we have some other issues. May not be applicable if they have hearing issues on one side or both sides, but that's one way that we can test for that as well. The others, olfactory, if most of our offices have coffee in them, so that's one way. If you just have them like close one nostril, have them close their eyes, bring a familiar scent. So like coffee and vanilla are the two that are probably the most common. If they can smell it and identify the smell, perfect. And test the other nostril as well. We want to do obviously both nostrils since each is innervated by one of the respective olfactory nerves. Optic nerve, if they can see out of their eye, that's a pretty good way, but you can like formally test with the Snell and eye chart, although I think Nick might be the only one who has one relatively close if Dr. Garcia doesn't mind you bringing patients in the hallway. We went over the oculomotor, trochlear, and abducens, but trigeminal, so that's has both sensory and motor function. So facial sensation, you can test light touch or like sharp dull sensations, or just have them clench their jaw. That's the motor component of the trigeminal, one of the motor components that you can easily test. For facial nerve, again, it is sensory and motor. The sensory component is part of the taste on the tongue. I believe facial is the posterior third of the tongue, but facial expressions are very easy. Have them smile, puff their cheeks out, wrinkle their nose, raise their eyebrows. That covers like all components. For glossopharyngeal, the typical doctor's office, open your mouth, stick your tongue out, say ah. If you see their soft palate in the back of their mouth rise, glossopharyngeal's good to go. Vagus nerve is responsible for the gag reflex, but also if their heart is beating, they're breathing, vagus nerve innervates all of the viscera as well. So if all of that's functioning, their vagus nerve is working to a component. Accessory nerve, so trap and deltoid are innervated by the accessory, so just easy MMTs for those two. And then hypoglossal, if you have the person stick out their tongue, it should go straight. If you see it deviate to one side, that's when there's an issue with one side of one of the hypoglossal nerves. Any questions? No?
I have one.
Yes.
All right. So when do I do these and when do I not do these? It's like if it's a lot of work. So what am I trying to rule in or rule out or what? Yeah, go.
For any, the ones that I would most commonly do, especially post-concussion, are the ones that they are bolded, kind of hard to tell, but ocular motor, trochlear, abducens, and vestibular cochlear. So 3, 4, and 6, we always remembered that in school, 3, 4, 6 make the eyes do tricks. But those 3, if you have any cranial nerve abnormalities, that's going to make that visual component that much harder if you can't move the eyes properly. So even like just doing an H pattern will cover all 3 of those. I've seen a lot of people do an H pattern, then come right into like the middle of the H and come towards the nose to look for that convergence. If you can get really darn close to the nose within 5 centimeters, if you're kind of close and like, oh, that might be 5 centimeters, then I would measure. But that's an easy way to get that convergence too. But just making sure that the eyes are able to move properly. And then vestibular cochlear can be, that can help you rule out whether it's a vestibular issue as far as a vestibular hypofunction on one side due to a nerve issue. So if they have damage to a vestibular cochlear nerve, their vestibular system on that side is going to be pretty shot. So their balance will be off because they're only getting input from one side. So they're getting a lot of input on one side, no input on the other. If they haven't accommodated to that yet, they're always going to have that sensation of dizziness because your brain is getting a ton of input from that side that's still working. And that tells your brain, hey, I'm spinning, even though you're not. And that's where like a unilateral hypofunction causes those issues. Does that make sense? Okay. Did that answer your question, Travis?
Oh, sorry. Yeah. I thought I was muted. So yeah, but how does that drive treatment? Like, oh, they tested positive for these, so now my treatment has to go here versus like, whatever, I'm just gonna do the same shit with them.
So not that it may necessarily change what you're doing, but it can give you more insight as to why they have certain deficits. So if someone has an issue with, say, their abducens, their eye can't look towards their lateral side. So that can influence then their ability for their eyes to track all the way. If their other eye still is moving properly, if I say my right abducens is no longer functioning, if I had to look to my right eye is not moving, but my left eye is going to. So then you have issues with that binocular movement. So it may not necessarily change what we do. It'll just give you more insight as to why they may have certain deficits, things like that.
And for concussion type stuff, is there specific areas of the head that, oh, I got hit from the side, or I got hit in the front, or I fell backwards and hit the back of my head? For cranial nerve type stuff.
Cranial nerve type stuff, not that I've come across. If you think though, vestibular cochlear, I mean, that comes right to the ear. So any like blow to the ear can start to mess with hearing, things like that. Not in the research that I've seen. It's also not something that I have specifically tried to look into though.
Okay. All right. So
all right. Moving on, so the BEST test. This is a component of that SCAT-5 that we went over before. Very similar to like the modified SITSIB, which I know a few of us will commonly do. Just need to have like normal floor surface and a foam surface available, and a stopwatch or just some ability to time them. This does go through the so on the instrument details, of course it's going to download. So it goes through kind of the whole thing of it. But those testing positions, so eyes closed, should keep the hands on the hips. The first testing position is feet together. Second is single leg balance. And then the third is tandem stance. And you should be testing their non-dominant foot. So with the tandem stance, it's their non-dominant foot should be behind them. And then
what do you consider like non-dominant? Like,
I would ask them, like when they kick a ball, which foot would they naturally kick with? That's probably the easiest way that I've learned how to determine if someone is.
I just find that well, not odd. I guess like I look at it from like a basketball standpoint, something like that. Like with a layup, like if you're right-handed, you go up off your left foot. Like I don't know if this is other people or if I'm just overthinking this. Like I'm naturally much more balanced on my non-dominant foot, I guess.
I am too. But if there was one, certainly if you think it would differ significantly from side to side, like this is just one tool that you could look at. You could do even just single leg balance to see if there really is a difference. But what this is looking at, so these are the errors that we're looking for. So since their hands should be on their hips, if their hands lift off of the iliac crest, if they open their eyes, step, stumble, fall, if they move on the leg that they're standing on, if the hip moves into more than 30 degrees of abduction, start to use that hip strategy, or if the forefoot or heel lift off, or if they stay out of that test position for 5 seconds, each one of these would count as 1 point during the testing. So ideally, the score should be a 0. So the lower the score, the better. And it's just looking at their ability to maintain the balance. Any questions on that one? No? All right. Buffalo concussion treadmill test. So this is, we have a treadmill in Allentown. Does UMac have a treadmill? Okay. And Bangor has a treadmill, or at least they did.
Nope.
Not anymore? All right. So for Allentown and UMac, this one will be helpful. So the starting pace for the treadmill, if they are shorter than 5 feet 10 inches, start at 3.2 miles per hour. For someone who is taller than 5'10", it starts at 3.6 miles an hour. If that feels like a very slow speed for them, it can be adjusted depending on athletic status, and just that overall comfort of the pace. And they should be starting at a brisk walking pace. The incline starts at 0, and then for every minute, it increases by 1 degree for incline, all the way up to 15 degrees. So 15-minute test, if they make it through the whole thing. There is, so it has a testing protocol, which I summarized for you. You should have the RPE scale and the VAS scale in like clear sight for them, because at each minute they should be asked to rate their RPE and their VAS. Any increase of 2 to 3 from baseline would be one of the criteria to stop. But here's also the stopping criteria. So symptom exacerbation, voluntary exhaustion, or just tired. Any like rapid progression of complaints. So especially for concussion, any of those symptoms that are increasing. If they reach 90% of their max heart rate for their age, or if they just ask to stop. We have, most of the offices I think have a pulse ox, which I could argue sometimes that heart rate I would say is reliable, sometimes not. I would just pay attention to the pleth wave on the pulse ox. If you have that normal pleth wave, I would think it's a bit more accurate. If it's just kind of like jumping and kind of going flat, I wouldn't use that too reliably. A lot of times people will have some sort of smartwatch, something like that, that will monitor heart rate. Those can be decently accurate depending. But here's what you're filling out. So starting at minute 0, so we want to see what their heart rate is when they're first starting, so not resting heart rate. As soon as they start walking on the treadmill, we want to get what their heart rate is. And then the RP and VAS scales, which are handy right here to print out if they are needed. And then each minute, as long as they don't meet any of the criteria to stop, you just increase that degree of incline by 1 degree. And that overall goal is to see what level of exertion are they able to exercise at symptom-free. So even if you're looking to get someone back to work, an athlete back to whatever sport they're playing, just that some sort of activity daily is super beneficial. But if we're able to determine that they can safely exercise with their heart rate under this level, that's kind of what we're looking for. And then as things are improving, to look at this again and redetermine, okay, now you're able to exert this much with your heart rate getting up to this many beats per minute without that symptom provocation. Any questions on that one? Okay.
You're just monitoring symptoms at certain heart rates. So like, oh, they did the test the first time. Once they get up to, 60% of their max, they start to have concussion symptoms, and then, okay, you back them down.
Yep.
And then continue to retest that occasionally.
Yep. So a good way to progress kind of where they're at as far as a component of return to sport. But even just if someone really wants to do like daily workouts at home, but they're like, how do I know if I'm doing too much? Giving them a baseline of, okay, you're able to do this test and get your heart rate up to this number without symptom provocation. That's ideally where we want to start, because the better the blood flow, better the oxygen, better healing for the brain. So as more activity as we can have them do without that symptom provocation, that's what we're looking for. Since Bethlehem and now Bangor don't have a treadmill, Buffalo Concussion Bike Test is a modified version of it. So if you start at the lowest resistance setting for the bike and then increase every 2 minutes during testing, the outcomes have been very similar to the treadmill test. Has the same thing. These criteria I didn't go over with the treadmill test, but they are the same as for the bike test. If absolute contraindications and relative contraindications, so something to keep in mind before you do any of the testing. But Same stopping criteria as for the treadmill test. But this one, so this is a much longer test if they have that endurance component. So this goes by stage, so whatever level the bike is getting to, this is how many minutes. So again, every 2 minutes you're increasing. So if can end up being very long if they have a really good tolerance to it. But same thing, you're just getting that heart rate, RP scale, and the VAS scale with that. So a good alternative when you don't have treadmill. And then, so this was from the International Consensus Statement for Concussions, some guidelines for graduated return to play. So those first few days, so it's recommended 2 to 3 days of no activity, no physical exertion to really start that recovery process for the brain. But then very quickly getting into that light aerobic exercise. So each stage, we're looking at like that first stage, just increasing that heart rate, gradually increasing movements, really then focusing on that overall exercise tolerance, coordination, and cognitive load. And that's something that not everyone will always think of when it comes to concussion rehab, adding in that cognitive component, because a lot of people will have that cognitive fatigue as well, in addition to the physical fatigue. Just adding in more of that like brain train, like brain games kind of thing. And then working back to that full contact practice and then return to play. For criteria for discharge, being symptom-free at rest, symptom-free with exertion, and normalcy with neurocognitive testing. Does anybody have any questions? Like I said, we had originally set time aside to like do some of like the testing, things like that in person, but I'll find family member, an aide in the office, someone to practice on.
And then hit him in the head? That seems mean.
No, I would not recommend that. So I did my research in school on concussion rehab, and we didn't think that that would slide through the board.
IRB be mad about that? Yeah. My kids have concussions all the time, so as soon as the next one comes, I'll zip them right over. We'll do a lab class.
Oh man. But yeah. Any questions though that anyone has?
So does anybody have heard any reasonable explanation for why it seems that concussions occur at a higher rate now than, let's say, you guys are younger than me, but let's say when I was, because like nobody had a concussion, like nobody in high school, even in college, very rarely. What's up? Oh yeah, that kid, he can't go to class. Well, never in college. Like, where's John? Oh, he can't go to class. He had a concussion. They may know why that is.
I think a lot of it has to do with just now knowing like concussion, just knowing more of what happens down the line to the person, almost scares people into thinking, oh, I need to take care of this versus, oh, it'll be fine. I think that has some component to it.
Yeah, the best explanation I had, so I took my kid to urgent care, and the doctor that saw her was the team doctor for the Patriots for a long time, for the Steelers and Denver Broncos, I think. So he'd seen a lot of concussions, and he explained to my daughter that, yeah, kids have concussions more now because they're constantly on screens. So what happens is screens like stimulate your brain, and they're hypersensitive now. So they're constantly getting all this input. So they're at this level of heightened excitement. And so they're much more susceptible to concussions than people when there weren't all these screens. I thought that to be interesting. I didn't ask him for any research to back that up, but it did seem to make a lot of sense to me. Yeah, I don't know if it's oh, we're more aware of these now. Like there's kids in my kids' school that are gone for half a year, like physically cannot attend school because they have it so bad. And my kid, I don't think she is like a faker. Maybe she could be, but she's still like not right. And she like tripped and like hit her head on the side of the garage door. Like I'm still half thinking she made it up, but she has all these concussion symptoms and like it's stopped her from doing things that she wanted to do. So she definitely has it, but she's on a screen constantly.
Yeah.
So yeah, I think that might have something to do with it.
Yeah. One of the places that I had shadowed, the PT did an eval for, she was 12 years old. It was her 5th or 6th concussion. And that was before grad school, but that was like, it just blew my mind how many concussions she had, and she was only 12.
Yeah. So yeah, it's interesting. Luna.
Oh, Luna.
She came to say hi.
Yeah, that was great, Lauren. I need to practice this testing. I don't know if I can, like, I'd be able to whip all that stuff out immediately. But I should, like, now I don't coach anything now because nobody coaches anything, but I would like we play soccer, so kids get hit in the head all the time, and I would do some basic like cranial nerve stuff and look at pupil dilation, that kind of stuff. But this is more advanced, so I like this stuff a lot better. I just gotta practice it just so I can know it. So
The SCAT 5 would probably be really useful. Looks at a few more components. Do you normally do baseline testing for the kids?
in schools they do, in youth programs we don't. So yeah, they do. What's it called? The baseline test. I can't remember. You broke up. What'd you say?
Impact is a
Impact. Yeah, impact test. So in all school sports, once you get to middle school, then they make you take an impact test now.
So one thing that was very interesting that we found when we did our research in school, they found that a lot of kids, high school and college age, would intentionally try to do poorly on baseline. So if they did actually have a concussion, their scores would reflect pretty darn close to their baseline. So then they could go back and play.
Yeah.
Yeah.
All right. Thanks, Lauren. That was a lot of work and I learned a lot. So I appreciate that.
That was useful. If there's any questions, just let me know.
Awesome.
Great.
All right, guys.
Thank you.
Have a good rest of the day.
Adios.
Thanks, Lauren. Bye, guys.